One past the hour, so I think it's appropriate to begin. So I want to welcome everyone to the 16th annual Norman R. Seay Lecture that is sponsored by the Charles F. and Joanne Knight Alzheimer's Disease Research Center here at Washington University. I'm John Morris, and I'm the director of the Knight ADRC. And just to give a bit of background, in the year 2000, I invited Mr. Norman Seay, who I knew through caring for one of his family members, to help form an African-American advisory board so that we increase the number of individuals, people of color, who were contributing research data, so that we learned about Alzheimer's disease, not just in upper middle class white people, but in people underrepresented in research. And Mr. Seay was very gracious in accepting the role of chairman of this new African American Advisory Board. He has a long history dating back to the 1940s of his civil rights activity here in St. Louis. And was highly regarded in the community, and he formed a wonderful African American Advisory Board. He had a small stroke in the year 2006 and didn't wish to continue as chair of the African American Advisory Board, so he stepped down, although he remained an African American Advisory Board member and a very, very active and vocal member. But when he stepped down, I decided that we should have an annual Norman R. Seay lecture in his honor for helping us become more welcoming to people underrepresented in research. And so that's how it began. And we've had a distinguished panel of individuals who have been the Seay lecturers, and we're delighted that we have another such individual today. I do want to recognize all of our African American Advisory Board members who are participating virtually today, including the chair, Reverend Douglas Petty, and Richard King and Arlene Moore, who participated in the Seay Planning Committee activities. And I want to recognize the newest member of the African American Advisory Board, Emily Pitts, who is also a board member of the Greater Missouri chapter of the Alzheimer's Association. So before I introduce our speaker, I'm very pleased and delighted that David Holtzman is going to make some welcoming remarks. We all know Dr. Holtzman. He has become the Barbara and Reuben Morris III Distinguished Professor of Neurology. He is Associate Director of the Knight Alzheimer's Disease Research Center and Scientific Director of the Hope Center for Neurologic Disorders, and is a recent past chair of the Department of Neurology, where he served very admirably for 18 years. He has many, many honors, and one of them is that he was elected to the National Academy of Medicine of the National Academy of Sciences, and he's also a past president of the American Neurologic Association. So Dave?
Well, thanks so much, John. I'm so happy to mention that this lectureship began just after I became chair of neurology, and I wanted to thank the leadership of many people at the university, including, of course, Dr. Morris, but also the dean. Then it was Larry Shapiro, the African American Advisory Board of the Knight ADRC, and of course, Mr. Seay, and for many others for creating this important lectureship. The Seay lectureship highlights one of the many activities and initiatives that the university, the Department of Neurology, and the Knight ADRC carry out and participate in, which I really think indicates our commitment to a vision of a culture that supports diversity, equity, inclusion, belonging, critical thinking, and creativity. And while we still have a lot of work to do to continue to improve our local and national culture in this regard, this lectureship each year has allowed us to reflect on important topics relevant to improving our culture, as well as learning more about issues relevant to dementia and Alzheimer's disease. So with that, I turn this back to Dr. Morris to introduce this year's speaker.
Great. Thank you so much, Dave. And it's a real pleasure for me to introduce as the 16th Seay lecturer, Dr. Jeffrey McClean. Jeff received his undergraduate degree in biology at Harvard University in 1999, and then entered medical school at the Uniformed Services University of the Health Sciences in Bethesda, Maryland, graduating in 2005. He did his residency in neurology at the San Antonio Uniformed Services Health Education Consortium, completing that in 2009, and went back to Harvard for a year to do a neuromuscle fellowship. In 2010, he went back to San Antonio, where he joined the Wilford Hall Medical Center and quickly rose through the ranks of the medical center and the Uniformed Services University of the Health Sciences. He currently is an associate professor of neurology, but since 2017 has been the program director for neurology, and last year took on the additional administrative responsibilities for the as deputy chief of Department of Medicine there. I've known Jeff through mutual activities at the American Academy of Neurology, and it's been a pleasure to see Jeff rise to leadership positions there as well. In the year 2020, he served as the chair of the Special Commission on Racism, Inequities, and Social Justice, and issued a position statement for the Academy on systemic racism and inequities in society. He also is leading, he does many things, but he also is very importantly leading a subcommittee, the Inclusion, Diversity, Equity, Anti-Racism, and Social Justice Subcommittee, or IDEAS, which is going to implement the various pledges, positions, and directives that the Special Commission provided us. And he's here today to discuss forces and stumbling blocks for organizational equity, diversity, inclusion, implicit bias. Jeff, it's a real pleasure. And someday we will get you to St. Louis in person, but we are looking forward to your lecture.
John, thank you so much for the kind introduction. And thank you all for being here, and thank you for the invitation. This is truly a privilege and an honor to be invited to be part of this tradition. I have to say, when John reached out to me about this, I didn't know of Norman Seay, but as John told me about him, and I went on to read about him and his work, just the sense of honor and being part of this just rose the more and more I read. I talked to a good friend of mine who's from St. Louis, Jason Purnell, who was actually previously on the faculty at WashU, and he and I were roommates together back in college. And I talked to him, and first call after I got the invitation, and he actually had met Norman Seay as a child, and his father knew Norman Seay, and they were just both thrilled for me that I was invited to do this. And I had really hoped to be there in person with you all. I was looking forward to it. For a time it looked like we were going to be able to do it in person, and of course, it wasn't the right time. I will say that I've only given one in-person talk since COVID started, and that was relatively local at the Texas Neurologic Society annual meeting. And normally, as you can see, my day-to-day, I'm wearing a military uniform, which they're relatively baggy. For that talk, I wore a suit for the first time in well over a year, and I realized that my clothes shrunk during COVID, that it was a little bit tougher to get into my suits as I was trying them on. So in some ways, maybe it's a little bit better that I'm able to do this virtually until I have a chance to either get some new suits or adjust the sizes there. Um, I I do want to say just briefly about John Morris before I start. Um, Thank you again for inviting me for this. I don't know if John remembers this, but the first time I remember meeting John personally, I knew of him and had heard of him and his work before, but my first personal interaction was when I participated as a participant in the American Academy of Neurology's leadership program for early career neurologists. And one of the events that we had was to attend a leadership dinner with the members of the board of directors of the Academy, on which John sat. And we were in Philadelphia, I believe, and they had us all on a bus together going to the location for the dinner, and I happened to be sitting next to John. And it was just a really great conversation that I've never forgotten. And it was really amazing to me that, you know, this senior leader within the academy and someone that I looked up to took such a personal interest in me, and really reached out in a way that was so authentic. And for those of you that I'm sure know John and have known him for years, none of you will be surprised by this, but it made me feel incredibly welcome in the organization right away. And so I just want to thank John publicly for that. So moving into my talk, as I thought about what I wanted to talk about and how I wanted to shape this, I wanted to bring maybe a little bit different perspective. As I look through the past Norman Seay speakers, I think, you know, many spoke about research specifically in Alzheimer's, and that's not my area or my expertise at all. As John said, I'm a neuromuscular neurologist and clinical, not a researcher. But what John asked me to talk about and what hopefully will be helpful is thinking about some of these issues from a little bit different perspective. And I think ultimately it all ties together. Hopefully you'll agree. So I wanted to talk about, you know, some of the things that can drive organizations to pursue equity, diversity, and inclusion, and some of the things that can get in the way of that pursuit. And initially, when I envisioned this, I thought I would go through sort of a laundry list for both and give examples. And as I had started to work on that, I thought it would be better to hone in on something more specific. And in addition to that, I had a recent experience that really helped shape my thinking about this. So I want to share that with you all, and hopefully get you all thinking along the same lines of what led me to this, to putting this together this way. So I am actually currently the acting chair of our Department of Medicine, which has 13 different services and subspecialties, including neurology. One of them is gastroenterology. We have a relatively small number of subspecialists within that service that perform some advanced procedures. Recently, a concern was raised to me about the technical competence of one of those physicians. And I had to review and make decisions about the plan for how to proceed, given the concerns about this individual's ability to technically provide safe care to our patients. So, you know, this is a high stakes decision that involves somebody's career on the one hand, Obviously, their personal well-being has long-term implications for their practice going forward. But also, on the other hand, if indeed the person poses a risk to patient safety, that is the highest priority. So this, for any that have been in similar situations making these kinds of decisions, is always difficult. And the piece that I want to throw in now and sort of ask you all to think about is, this person happens to be a Black woman, this physician. And my question to you all is, should that matter to me from my perspective that she's a Black woman? Should that matter or factor into the decisions that I have to make with the information available to me, as I'm determining the best course forward? Should that be an explicit part of what I'm thinking about? And so I throw that out there for you all to think about and keep in the back of your mind. We'll come back to that at the end, but that really shaped a lot of what I want to talk about here today. So next slide, please. Briefly, just in terms of disclosures, I don't have any financial disclosures to make. And the only real disclosure is that these views and opinions are my own, and I don't represent the American Academy of Neurology, the Department of Defense, despite my uniform, the US Air Force, or the US Army. Next slide, please. So what are some tips in terms of the best way to start a presentation? So I tried to early on in this make a small self-deprecating joke about my suits not fitting me. Now, whether it was delivered well or whether it was funny, I'll leave to you all to judge. It's hard to say when everyone's got their cameras turned off, so I can imagine that you all were laughing and amused, even if perhaps you were not. Next slide. But the point is that often it's fairly commonly held and fairly widely thought that a good way to start a presentation is to use humor to engage with your audience, make them more receptive, and to come across as more likable. So you can get this from multiple sources. Next slide. When you look at public speaking tips from the best TED Talk speakers, next slide. Number one is to use self-deprecating humor. And I like this one in particular because it talks about a particular presenter who doesn't have a dynamic physical presence, and he's an academic. So when he's speaking, he has to overcome this perception that he's likely to be boring. And so I find that a particularly apt example. So the question is, does this work? Is this effective advice? It's very common. We've probably all heard this, if not passed this on to those that we train and mentor, that using humor in presentations is good. And is that good advice, and is it effective? Next slide. Next slide. And does it matter the gender of the person delivering the joke? Does it matter if you're a man or a woman, how good this advice is? Next slide. So there's a recent, relatively recent now, from 2019 article in the Harvard Business Review in which they looked at this and presented their findings. So next slide. What they did was they took the basis of what their study was that humor can be construed in different ways in a professional setting. Like, it would be seen either as functional or disruptive. And in addition, we know that people have different implicit or unconscious expectations of men and women, and that we often interpret people's behaviors in ways that adhere to those implicit or unconscious expectations. So the question they asked was, so will the same use of humor be interpreted differently based on whether the person utilizing humor is a man or a woman? Next slide. So what they did, they set this up is that they took one male actor and one female actor who played the role of a retail store manager. They each recorded a presentation of a performance report to two additional actors who were the regional managers. They each recorded two versions of the presentation. The presentations were otherwise identical. They each had a script that they followed that were identical. In one version that each of them did, there was no humor involved. In the other version, there were 5 humorous statements included in the presentation. These were recorded and screened to over 300 US employees from various industries. Next slide. They also received a resume, which was essentially identical other than the name and their work background. And the results were interesting. Overall, the viewers, of the 300 people that reviewed, overall, they were much more likely to score the woman's use of humor as less functional and more disruptive, whereas the man, again, using the same presentation, the same jokes, was perceived as having a higher status, better performance, and more leadership capability. Next slide. Here's some of the specific comments. When they talked about her, they said that she showed poor judgment in using jokes, and she was trying to cover up her lack of actual business acumen by making these jokes. Whereas for him, he was witty and using humor so he didn't come across as too stern. And he was also adding this humor to break up the monotony of his presentation. So everything else was the same, the only difference being the man was perceived very differently in why and the effectiveness of his humor when compared to the woman in this study. Next slide. So why is this? Why might this be? Many of you may be familiar with Thinking Fast and Slow by Daniel Kahneman, who's a Nobel laureate in economics. And he talks about, I'm going to very much simplify it, but he talks about 2 types of thinking. Next slide. System 1 and System 2 thinking. And so System 1 thinking being the fast, everyday, continuous thinking that we really do most of the time automatically without much effort or without specifically focusing on something. This is the thinking that is really automatic and effortless, is often driven by impulses, intuition, and it's fast, but as we're going to talk about more, it's often error prone. System 2 thinking is typically only used when we intentionally sort of switch it on when we have to divert more attention to something. It takes a lot more time. It takes a lot more effort. It is much slower, but it also, when we use it, tends to be more reliable. So that's the breakdown of System 1 and System 2 thinking. Next slide, please. So the example I often like to give or ask people to think about, and this happens with me more frequently than I care to admit. As I was talking about with John as we were getting onto the call, I have an 8-year-old son, and my wife and I take turns driving him to school in the morning. So some mornings I drive one way to get to the hospital, and some mornings I drive another way to get him to school and then go to the hospital. And many times, again, more than I care to admit, I either have him in the car and go the wrong way to go to the hospital, or I don't have him in the car and I go the wrong way to go by his school first. And hopefully, many of you have had similar experiences, and I'm not alone in doing that. But I use that example because it's an example of how system one thinking can really lead us to do things that conflict with our conscious and explicit intentions or beliefs. So I get in the car fully intending to take my son to school, or I get in the car fully intending to go to work. But because I'm using system one thinking and I'm not devoting the energy or attention to shift into that system two thinking, my decisions that I make automatically and effortlessly as I'm driving actually conflict with what I fully intended to do. And this, to me, gets to why implicit bias is both so important to talk about and understand and so insidious, because all of us have inherited and learned and absorbed ways of thinking and ways of looking at the world and ways of looking at people that inform our thinking and inform and strongly influence the way we interpret others' behaviors, and sometimes in negative ways, and sometimes leading us to make mistakes that we're not realizing, and sometimes we may be doing things that are actually conflicting with our conscious beliefs or explicit intentions. In medicine and in many other fields, we're often taught to trust our instincts, but our instincts can often be misleading if we don't understand from where they come, and they can often be unfair to the individuals we are interacting with. Next slide, please. Some other examples of this from various industries, and many of these will probably be familiar to you all. I'm going to try to run through these relatively quickly, but I think they're useful to just think about examples of this. So this is pretty well known in various versions. People have heard lots of examples like this, but in this particular study, what they did was they gave resumes that were identical, except for one had a name associated with it that would typically be associated with an African American, and then another resume with the same history, background, qualifications, everything else the same, but the name on top was with a name that would typically be associated with white American. And the resumes, although otherwise identical, associated with a name that would typically fit a white American, that resume was 50% more likely to be selected for a callback for interview by hiring and selecting authorities. Another that was in academics, this was looking at hiring a lab manager for a research lab. And again, when looking at CVs that were otherwise comparable, men were consistently rated as both more competent and more employable and targeted for higher starting salaries and more mentorship, even when controlled for level of experience, level of background, and the other factors you would get from the CV. Next slide, please. The top one is similar. Again, multiple studies have looked at this with CVs, changing the names. Some of you may know of A.M. Barrett, who is a neurologist. She's a full professor, very well established in the field, and she does a lot of research in neurobehavioral and neuro rehab both. I asked her once, why she goes by AM. The initials AM is what she goes by, and she explained to me that early on in her career, she believed that when she was submitting manuscripts for publication, research proposals for funding, and so on, that she was not being given the same opportunities. She wasn't being selected at the same rate, despite feeling that the quality of her work and her experience was on par with others. She was having more things rejected, and so she made a conscious and deliberate effort to change her name so that her gender could not be identified. And so she has professionally since that time gone by AM. And she, of course, this is an N of one, and this is her personal story, but I think that probably many people can identify with this. She noted a significant change in terms of her ability to get published and procure funding for her research. And she's had an incredibly successful career, but for her, the turning point was really when she made that change to take gender out of the review processes. This next one I find interesting. This was in the legal field. What they did here is they generated a fictitious legal memo, and the memo had 22 errors deliberately included, and those errors were a range of spelling, grammar errors, factual errors, and analytical errors. And they were distributed to partners in a law firm, and various law firm partners to edit and evaluate the quality of this legal memo. Half of them, again, indicated that the author was African American. Half indicated that the author was white. And consistently, the partners found more of the embedded 22 errors. The errors were the same in all the memos, but they were much more likely to find those errors when the author was Black than when the author was white, from their perception. Next slide, please. So, in none of these cases, I think, would any, or at least the majority of the people involved, express an explicit or conscious intention to selectively discriminate based on race. But unconsciously, implicitly, time and time again, when this is looked at, we see evidence that we make those decisions and we make those interpretations. And I want to be clear that this is not limited to white men that have these biases. We all, as I said before, and I'll stress again, we all have these biases. Interestingly, in at least the Harvard Business Review study that looked at humor in men and women, both men and women rated the woman's use of humor as less functional and more disruptive. That wasn't just men that viewed it that way. It was also women, and multiple studies that have looked at this have shown that even people of color and underrepresented groups often hold some of the negative, implicit, unconscious biases towards members of their own group. And because again, these things are so unavoidable and ubiquitous in the environment that we all grow up and operate in. So it's very difficult to escape these things. So I think probably most of you are already familiar with this idea of unconscious or implicit bias. But just to briefly review, these are, associations, attitudes, preferences, assumptions that we're often unaware that they exist at all, or at least we're unaware of their origin. And as I've said, and hopefully made a case for, these associations, attitudes, preferences, and assumptions often have a significant impact on the choices and actions we take. And actually, in many cases, an individual's behavior can be more accurately predicted by their implicit biases than by their conscious or explicit beliefs or values. As I was saying before, or alluding to before, this is not the same as racism, by which, at least the way I'm using the words here, is generally a more explicit form of discrimination. These are really unconscious, unintentional beliefs and ultimately decisions to which we are all vulnerable. Next slide, please. So how about in the field of medicine? People get into medicine and because they want to take care of patients, they want to do the right thing for people. So are we any better? Can you advance, please? So this was a systematic review from 2017 on implicit bias in healthcare professionals. Next slide. What they did was they looked at 42 different articles that in each of those articles, they looked for evidence of implicit bias in healthcare professionals. And of the 42 articles that met their inclusion criteria, 35, in fact, had positive findings for implicit bias in healthcare professionals, primarily based on race, ethnicity, gender, age, and weight, although some other factors were included as well. Not all of the studies looked at the correlation between quality of care and the presence of implicit bias, but those that did try to look at that correlation did in fact find that as rates of implicit bias increased, the quality of care decreased when applied to those in the groups that were the recipient of the bias. Next slide. This is an example of one of those studies to give you. So this is an older study from 2007 looking at physicians' decision whether or not to administer thrombolytic therapy for acute coronary syndrome. They looked at 287 internal medicine and emergency medicine residents at 4 academic centers. Because of the locations, the populations were almost entirely white or black. They didn't have any other racial groups identified. Of the 287 residents, none in the survey expressed an explicit preference based on race. Next slide. However, they administered implicit association tests, which is one way to assess for the presence of implicit bias. It's somewhat debated, but fairly well established and widely used measure. And what they found was that, in fact, despite the lack of any conscious or explicit preference based on race, that in fact there was an implicit preference for white Americans, and specifically an implicit belief that Blacks were less cooperative with medical procedures and less cooperative in general when compared to white Americans. And so what the impact of this was that then in the clinical vignette that required decision making, as these pro-white biases increased in those that had more pro-white bias, the likelihood of offering the appropriate thrombolytic therapy to Black patients decreased. And so again, despite a lack of explicit or conscious preference, there was clear evidence of an impact on the care that would be delivered. Next slide. In neurology, there have been multiple studies looking at not necessarily implicit bias specifically, but looking at various conditions and disparities in access and outcomes related to neurologic conditions. This slide was actually put together by one of the American Academy of Neurology diversity leadership programs, and I have borrowed this from them. What I like to point out is a couple things about this slide. One is there's multiple, it's all throughout our field. And this is not unique to neurology or the neurosciences. I've looked in other fields and spoken with colleagues in other fields and looked at the literature from other fields. And the more you look, the more evidence there is of these disparities across the field of medicine. The other thing is that these things, despite the belief of some, don't just automatically get better over time because our population is becoming more diverse. So these are recent, and the ongoing studies continue to show that these disparities exist. So it's not enough to just say, well, as we become more diverse, these disparities will just go away. I think there's ample evidence that that's not the case. And lastly, I like to point out, and this I think is the perfect forum for this point, and what is exactly in line with what Dr. Morris set out to remedy by working with Norman Seay and creating an African American advisory board, is addressing the issue from the second to last bullet, which was really looking at a lot of the trials that established the appropriate treatment for multiple sclerosis, and the fact that people of color were vastly underrepresented in the study populations that led to the development of what are our appropriate and the best evidence for our treatments. And I think I'm probably just preaching to the choir here, but the point I really like to make there is that, again, why it's so important to be aware and think about these things and how pervasive they are is that even if you are using the best available evidence, and even if you're using the best available science, that best available evidence and science may be tainted by bias in terms of how those studies were set up, and therefore potentially what we're considering the best evidence. And so I think it's very admirable that over 20 years ago, the Knight Alzheimer's Disease Research Center took deliberate and intentional steps to address this, because this is something that we still see now in many areas to this day. I see that John unmuted. Were you going to make a comment, John?
Nope.
Okay. Next slide, please. So tying it back to my initial question and the story I told about this individual physician, as a leader within an organization, when looking at this, I'm certainly someone who thinks a lot about implicit bias. I try to be aware of my own biases and be aware of this for others. But as I spoke to this physician and she expressed her concerns that many of the issues that had been raised about her, just in terms of bringing the information to me in my position as chair, that those were inherently based on bias, and that her other colleagues were not under the same scrutiny perhaps that she was, and that some of the complications that had been attributed to her and seen as a failing on her part were shared by some of her colleagues, and that she was being looked at differently. I don't know. This is fairly recent. I don't have enough evidence yet to judge whether that's true, but what it really made me think about was, whether it's true or not, it's not enough for me to simply be aware of bias and to individually work on bias for myself. It's really important that as an organization, that there's a process for addressing this, because by the time it gets to me, it may already be too late and unfair for a particular individual. And again, hopefully I've made the case for time and time again how decisions are made and how behaviors are interpreted in ways that may disadvantage some people. And again, just because we're seeing increased diversity in the general population, that has not equated to more diversity in organizational leadership. So this was looking at a study that looked at an article that looked at the CEOs of Fortune 500 companies, looking at trends from 2000 to 2020. It was published about a year ago. Next slide. Just to look at this, about 90% of Fortune 500 CEOs are white. When you add women, are white men. And when you add women, that number goes up to about 92.6%. Only 1%, just a small handful of Fortune 500 CEOs are Black, about 2.5% Asian, and 3.5% Hispanic or Latinx. So despite the workforce being increasingly more diverse, despite the workforce being now much higher numbers in terms of racial and ethnic diversity, women now make up the majority of the workforce, we don't see that same diversity reflected at the top. Next slide. What about academics and education? Do we do this any better? This was a, next slide, please. This was a report in 2019 from the American Council on Education. So despite the fact that almost half, not quite, but almost half of undergraduates now across the nation are non-white, only about 21% of full-time faculty in higher education are people of color. And that percentage declines progressively as you move to higher and higher academic ranks, from assistant to associate, full professor. You see fewer and fewer people of color, and similar trends hold for women as well. The number of college and university presidents that are people of color has risen pretty significantly in the past 20 years or so. It's more than doubled, but still only 5% are women of color. And I think very telling, students at institutions of higher education are much more likely to encounter people of color in servants and maintenance roles than they are as faculty. And that to me was an important point, because a lot of this again just gets back to what we absorb constantly, what we see, and how that impacts our thinking and the way we interpret the world and interpret the behavior of others. Next slide. So again, but why does all this matter? To me, it's the fact that despite the fact that we have significant evidence for organizations that there should be enough of an imperative that increased diversity leads to greater organizational success. There have been multiple studies that show this. We still aren't seeing those significant strides in diversity and leadership in any type of industry. And a big part of that in my mind is due to implicit bias, because we know implicit bias has been shown to impact hiring and selection when you're looking for leadership roles. So if you think about infinity bias, or the bias to be predisposed to positive interpretations for people that remind you of yourself. So when you take the fact that a starting point that most people in leadership are white men, and if many of those people then have and are impacted by affinity bias, who are they most likely to see themselves in? Other white men, and it becomes a self-perpetuating problem. This quote unquote benign bias, this is one that was pointed out to me, and I realized that I was falling victim to this, is that I noticed that when selecting some of my residents for particular roles and leadership roles, I would, if considering a male resident, just offer them the position or the role, or ask them to do it. If it was a woman, I often would think about, well, I don't want to overburden her. This might be too much. I know she's got, kids at home and she's busy. And I thought I was trying to think about and consider the individual. But in fact, what I was doing was actually bringing a bias. And what someone, pointed out the obvious to me is, just ask them, don't assume for them, just give them the opportunity and let them choose. And that's something that I've tried to intentionally change over the years, and hopefully have done a good job of. And then the last one that I like to point out is it's often hard to imagine what you don't see. And if we always see people in leadership roles that look a certain way, we get very comfortable with that. Sometimes it's hard to imagine anything different. And that ultimately gets back to people that are selected and chosen and promoted for certain positions. So next slide. And there's a high cost for these things to an organization. So if you don't have the diversity built into your organization, if you don't have that equity and inclusion, you're going to suffer from a lack of diverse ideas and perspectives that can impact your effectiveness. You're going to have a reduced ability to communicate effectively with an increasingly diverse customer base, constituency, or patients in the field of healthcare. It's going to be harder to recruit and retain diverse talent. You're going to have increased potential for crises related to these. You don't have to look hard in the news to see, every week, if not every day, there's another organization that has a crisis related to something to do with how they're dealing with some of these issues. And often the underlying issue, or at least an underlying issue, is a lack of diversity in leadership that could bring a perspective that would have proactively addressed these things, rather than trying to react to a crisis once it's occurred and try to fix a problem rather than address the underlying issues. And then along with that, without that diversity of perspective and those diversity of ideas and experiences, there's a reduced resiliency and a reduced ability to appropriately respond to these. Next slide. So what are some things that organizations can do? And I don't have the answers, and I don't think, I have not yet found a lot of great evidence for this, but some things that have been successful for some organizations. One is increasing awareness of implicit bias, both at the individual level and at an organizational level. So training and education, encouraging people to take the implicit association test for their own personal awareness, but not stopping with training and education, but really developing tools to evaluate an organization's processes and outcomes and products to make sure that these implicit biases are not impacting those things. Creating deliberate processes to reduce or eliminate opportunities for bias. So this, again, getting back to the case I used at the beginning of the female physician in our department. How do you make sure that bias is taken out as much as possible before it becomes a high stakes decision about somebody's career and livelihood at a department chief or credentials committee hearing or decision process? How do you try to make sure that that bias isn't already baked into what's presented? Because ultimately, just having diversity, having a diverse individual in one of those roles or on those committees or boards isn't going to be enough if their decisions are being driven and informed by biased information and biased processes. Ensuring that all leaders within an organization are explicitly responsible for and held accountable for promoting equity and inclusion. And so ensuring that when hiring and selecting leaders from CEO, senior executives, and so forth, that part of the interview and selection explicitly includes demonstrated competency in these areas, just like you would expect demonstrated competencies in financial management, in strategic planning. What kind of demonstrated competency does the individual bring in terms of equity, diversity, and inclusion? And similarly, how do you review this person's performance on these metrics on an annual, semi-annual basis? And finally, having meaningful communication. And again, I think I'm preaching to the choir here. This is exactly the kind of work that I think was done here in a very pioneering and forward-thinking way over 20 years ago by creating an African American advisory board to establish that meaningful communication with underrepresented groups and communities. So next slide. This is just a link to the implicit association test I mentioned a couple times. If you're not familiar with it, I highly encourage you. It takes 10 minutes or less to complete one. And it's a great way to look for your own personal blind spots. I always highly encourage this of everyone to take advantage of. It's free, takes a little of your time, and it can be incredibly insightful. Next slide. And I didn't leave as much time as I had hoped for questions or comments. I apologize. I usually like to leave a little bit more, but I'm happy to. I don't know if we have a hard stop, but I'm happy to take any questions or comments that we have time for.
Jeff, that was really wonderful. I don't know, can you see me?
I can, yes.
Okay, I'm holding up a plaque that commemorates your 16th annual Seay lecture. Can't give it to you in person, but we will put it in the mail and send it to you. And
Thank you.
I appreciate so much this really very compelling review of hidden biases and the challenges that they bring as part of being a board member for the Academy. Of course, I was given a copy of the book Blind Spot and the implicit bias test, as you just showed. And it's something that we reviewed as a night ADRC together. We went through that and tried to be aware of that. So we really appreciate your very thorough and universal characterization of these that we all share and how they influence us in ways that we don't always appreciate and can be negative. So thanks so very much for that. So
thank you.
I will open this up for questions. We have just a few minutes left, but we'll be happy to do that. So we'll see who has questions.
I have a question, John, for Dr. McClean. How do you explain implicit bias among women and among African Americans? Because you mentioned that women, gave lower scores to other women, and it wasn't a gender issue. And how do you explain that?
Jeff, before you respond, Dr. Collins Lewis is a member of our African American Advisory Board.
Okay, great. Well, thank you for the question. I think it's a great question, and I think it's an unfortunate fact of really the society we all grow up and live in. The images that we grow up seeing, the attitudes that we hear and take in, from our earliest days, teach us certain things, unfortunately, about people, and we all incorporate these into, our brains are sort of wired to take these things and allow us to interpret our environment, interpret people, and make judgments about people quickly. And we sort of we learn those algorithms very early on from people around us, images around us, media around us. So to give, an example that pertains to your question, when you think about women, women as well as men often have bias against women being being high career achievers. And that's related to when you think about what are the images that we all see growing up related to what it is to be a woman and what it is to be a girl in our society. And usually there are significant disparities, and we've all experienced this in terms of what we see, what we hear, what toys kids play with, what boys and girls are encouraged to pursue differently. And we all internalize those things, men and women, boys and girls. And so girls often don't feel that girls are as good at math as boys are, and are as cut out for the sciences as boys are. And girls unfortunately internalize that, and that persists with them as they become women. And so that is something that, despite being a member of that group, they're unfortunately also subject to that. And it's the same for Black people. This has been shown many times that Black children have internalized many of the racist attitudes towards skin color, that even, Black children see darker skin as a negative thing because they have, unfortunately, because of our society, internalized those things, or may see, because of what we see in media, are more likely to associate Black men with crime or other negative things than they are to be successful. And those are just things that are unfortunately so prevalent in what we all absorb, that being a member of that group doesn't make you impervious to it. Hopefully that answers your question.
Yeah,
or
that's
addresses
very
it.
good. Yeah, so it's kind of unconscious in a sense.
Absolutely.
Mhm.
And that's what makes it so difficult to deal with unless we talk about it, unless we look for it. Because I think there is often an assumption that, well, this is not something that I have to worry about. I know all about discrimination. I know all about bias. I don't need to worry about this, but this is something that we are all vulnerable to.
Yeah, thank you very much.
Thank you.
Jeff, it's about 5 minutes past, so I just, before we close, want to make sure you have a chance to look at the chat because many people are complimenting you, and I just want to make sure you had an opportunity to see the praise that they gave you. And as I indicated, it's all very, very appropriately merited. So thank you so very much. It's great to see you visually, and hope to see you in person in the not too distant future.
Thank you all. And thank
Right.
you, John. I really appreciate it.
Okay, take care. Bye-bye.
Have a great day.